There's some nuances that are specific to me. You guys just have to figure out how you do it, how you like to do it. I would suggest probably to do saline with an air bubble. That's kind of the textbook way of doing it, and with the compression of the air bubble. Once you get experience behind you, if you want to go straight air, that's up to you. The only difference is if you do wet tap and get that loss of resistance with an air full of syringe full of air, you're gonna get a pneumocephalus and instant headache right off the bat. They're gonna be like, oh my gosh, my forehead is killing me. I've seen it happen from a doc I was working with that uses air and got a wet tap. Where an air bubble saline technique, you may never, there are times you don't even know you wet tap. It's unusual. Usually if you get a good wet tap, size of the needle is anywhere between a 17 and a 19 gauge TUI. You pull that stylet out and CSF will squirt out the end of that tube. And so you pretty much know, and it's a solid stream. Because there are times that you get local out of it, because the local you infiltrated to numb their skin up. If you're not in the right space and you're in an area where there's local and there's pressure in there, you pull the stylet out. Local sometimes will squirt out, but it stops, right? Where CSF will just be like a.
My very first one did that
strain.
in Idaho. Skinny little thing, you could see your spinous processes from half mile away. I sucked really bad. Put it in, pulled out the stylet, and it's just shooting out. I'm like, wow. He's like, dude, he grabs it and slides it out. It was impressive how much that really suppressed. Wow, when I saw it squirted out. She never got a headache.
Hey, wait.
Never.
Can I video this?
Yeah. She never did get a headache. That was crazy.
So instead of seeing the blood, you saw the CSF. Well, I'll just pretend I don gloves, okay? So anyway, patient positioning is the most important thing for new learners especially. Even for experienced people, patient position will be the best thing you can do to make this placement the easiest as possible. Obviously, sitting is the easiest, and you'll get some patients every once in a while, they'll be like, oh, my last one they did laying. When we talk about labor and delivery, what is anatomically different between males and females when they're laying lateral? I'm not talking about boobs and stuff like that, okay? Hips. They have larger hips, and so when they lay lateral on a larger hip, then their spine has a further gap that gravity kind of takes it down, and so you'll get what's the word I want? Where the spine is just displaced a little bit towards the bottom of the table. I wouldn't do lateral unless you absolutely have to. Sit them up, even if they're contracted and in pain, even on girls that are like 9 centimeters and you're trying to hurry into a spinal. Those are times I have done lateral, but if they can tolerate sitting up, it's so much easier, so much faster. They'll get more comfortable quicker. Plus you get the voricity effect, which when they're 9 centimeters, they want that medicine down into their sacral, because that's where they're hurting. Anyway, beds should be flat. You will find those labor and delivery beds have those built-in air pillows that blow up for like lumbar support. They'll sit on it, and they'll be like this because of the air, so you gotta release the air. You want the bed flat. Even if the head's up a little bit and they're up towards the crack, then that'll tilt their hip, that'll throw their trajectory off. Anything you can do to get them totally flat and straight, so when you look at them, you should see C7 kind of sticking out of their neck. You should hopefully, if you can see all the spinous processes, or you can kind of see midline where their back kind of comes around and goes in. Midline, and if you can see butt crack, you want to line all those up. Now even doing that doesn't necessarily line up your spine, because they could have small curvatures, or just some girls will want to lean on one side because they're uncomfortable, and you just got to get them up, sitting straight. People will use a pillow sometimes for them to kind of hug over. Some people will pull a table in and have them lean on the table. I personally don't like that. I like them to lean over. Dan, I don't know if you have them do Indian style or legs off the bed. I usually just do, my personal I just tell them whatever's comfortable. If you wanna sit Indian style, or if you wanna sit legs off the bed. The only problem with legs off the bed sometimes is if they're shorter, you want them back further, and so when they get back to that point, they can't get their legs off the bed and they're kinda sitting straight, which is uncomfortable, obviously. So that might be a time to have them sit Indian style, which a lot of ladies like to sit Indian style when they're pregnant, cause it kinda gives them a place for their belly to go. Anyway, positioning's most important. First thing I do after I run through my interview, checking labs, making sure there's no contraindications, run through the spill with them, run through their health history, and sometimes depending on the process of where they're at and how fast they're going, I'll do all that while I'm preparing my tray. And if they're not too uncomfortable, I'll focus on that better so I can concentrate better on their health history. But I'll run through all that, put them in the position, and give them risk benefits, contraindications, alternatives, whatever. And then obviously we'll chart all that, but I do that at the end. I'm gonna look at their back. I have them reach over a pillow, slouch. You want them to do the, people say mad cat. So you want them to push their lower back out, and people struggle with that. I'll touch them here, and I'll say, right here where you feel me touching, I want you to push out against my hand. And people immediately will go, no, the other way. And then sometimes you have to show them, go around in front, walk around in front of them, I want you to go like this, push your back out.
Do that a couple more times, Ted?
No. Anyway, so I'll put them in that position. I'll feel the top of their hips unless I can see them. Most of the time I feel them. I'll reach my thumbs over and I'll start feeling for spinous processes. I'll realize where I want to go, whether that's L4, L4-5, and then I'll take a marker or a pen and I'll draw on their back. This is a little scratchy and I'll mark my X. And then I'll go to my tray and I'll open this up sterilely, don my gloves sterilely, and then I'll start setting my tray up. And usually this is a crappy tray table. If you have your big one, you can, with the drape, I'll kind of spread this out. So I would put this on the sterile drape if there was more room. I'd kind of set this over there on the sterile drape. Holy crap, what the crap is this for? Was that in there?
I think it's just protection so it doesn't bust the medicine underneath.
Oh.
You don't know
Never
that
seen
before,
that.
Ted?
I have never seen that
You should
before.
get that.
I'll go right off the bat, I'll go to my betadine, and this is probably what you guys will use 98% of the time. Betadine, I'll open it up, drop it in. Obviously that'll go in the garbage, not in the tray. I'll take my sponges, start in the middle from my mark, and work my way out. And you want to give yourself room as you do a prep that you can move at least up a space and down a space. So that's how wide of a prep at least you want. Throw that in the garbage. I'll do that 3 times, throwing that in the garbage. Now while that's drying, I'll go to my tray and set that up. And hospitals have gotten more cognizant, because of JACO, of waiting 3 minutes for betadine to dry, or any kind of prep to dry. Because especially with betadine, that's when it's dry, that's when the germs are dying and killing. If it's wet, it's not really necessarily effective. I'll pull my drape out, and every drape's different, but what I like to do, and this one I've never seen, this one's different, but the one I'm used to is I'll peel this off, and it's usually, I'll unfold it and peel the long one off that sticks across the top of their back, and then I'll actually take my glove and stick it to it, and I'll unfold it out, and I'll place it on, and that way, because you'll see people that are trying to flip this out, and then they're trying to open it up, and they're trying to flip it out like this, and it, it touches their arm or their body, and they contaminate it, and a lot of times don't even realize it. So I'll actually rip the sticker off, I'll stick my hand on the sticker, and then I'll unfold it. That way it's not like falling down and contaminated stuff. That's just a little thing I do. I'll stick the drape on sterilely. You gotta make sure when you push that sticker at the top that you don't go over the edge and contaminate. So you guys keep yourself sterile. You'll put the fenestrated open part window right over your mark, which sometimes your betadine will wipe off, but if I use my pen, it'll leave a red mark, even though the betadine cleaned off the pin part, it usually stimulates their skin to leave like a little red mark, and so you get a little, like a scratch
Don't
basically.
use your fingernail. I see some
People do that, yeah,
That's gross.
especially with spinals.
I thought you were joking.
Well, with a glove, you still have a glove on, but people will use, they'll
Some people are
mark it with
doing
a
it, they checked it
fingernail.
back before they had their glove on, they were doing it, before they prepped them.
Oh,
they find
really?
it, they'd be like, all right,
Yeah,
go
don't
right
do
there.
that. That's not good.
I used a cat key, you know, the pain pump key, I
Oh,
would just clean it off every time, but make a little circle with that, and that's doing what you're talking about, it leaves the mark, but it doesn't get washed off, cause it indents the.
yeah, exactly.
Everybody's got a different trick.
So anyway, sterile drape on, circle open the area, put your sticker on, fold it out. I really I personally wouldn't put them back this far on the bed. I would personally probably have them like this. That way when the drape comes down and across, I've got a table right here now. This table's way too low, but we'll deal with it. Now I've got a table that I can actually take, when I get all this stuff ready, I'll set stuff over here, so I don't have to constantly turn back and forth. I've got it all right here in front of me. Anyway, so that's drying, the drape's on. I'm gonna go to my tray and I'm gonna set everything up here. In this tray, like Dan said, every tray is gonna be different. You'll get used to your specific tray, your facility, cause they'll get what they like, and everybody, typically, a hospital will have a standardized tray. Now you may run into some facilities where some specific providers get specific trays, so you might have different trays. I think a lot of places have gone away from that and they're trying to standardize. But anyway, I'll go through, I'll open all 3 vials. You've got the NS, which is usually 10 cc's. You've got, usually it's 2% lidocaine, but this one's 1%. And so it's just how you set it up. I'll open that. A lot of kits are 5 cc's, some may be up to 10 cc's. And then usually the test dose, which is red writing usually, and it's half lidocaine 1.5%, 1 to 200,000. I'll open that up, and it's usually almost always 5 cc's, because you want to inject at least how much? How many? At least 3 cc's. And so I'll open those up. I'll take my my glass syringe, and I will put a needle on it, and there's usually sometimes a straw needle in here.
It's that red one.
That's the filter needle, but there's usually almost just even a straw needle and a lot of kits won't even have filter needles, and that's always a concern for some people, especially students, because they're like, you open vials, shouldn't you be using a filter needle? Yes, technically, yes, you should. You will have some kits though you may come across that don't have filter needles, and people don't use them, and they're not necessarily even thrown on a filter needle. I don't know if you've seen that, Dan, or not. I think a lot of kits
Most
aren't.
of the kids have that straw you're talking about.
Yeah, the straw, which, I don't even know if it's filtered, do you know?
Thought it was
Yeah, it might be.
filtered straw.
Anyway, I'm gonna pull up my NS, and have this full. Now, the one thing I wanna say, and this one's broke, and so this is a good topic. These glass syringes, especially after you lubricate them, they are, I mean, already this one's not even lubricated, and it's like, got very little resistance to it. But once you lubricate it, if you're not paying attention and you go like that, onto the floor, and when it hits the floor, it's not like, even if you had a sterile floor, you can't pick it up and put it back in, because it's glass, it's gonna shatter. And so you've gotta be careful. Once you lubricate your syringe and get it ready, don't tip it upside down, because it's gonna go somewhere. So I always pull it up. What I do is I end up filling it with NS, and then I'll put my finger over the end of it and I'll pressurize it, and when there's saline in there, this syringe will turn from this frosty color to a clear color as it lubricates and goes up against around the side of the plunger here, and that's how I lubricate it. So, and then after you lubricate it, it's even less resistant. It's even less resistant than it was before, which is all because epidural placement is done by fill, and so you want to feel that resistance as you're going through the ligaments and through the tissue. So I actually will pressurize it. It'll go clear as that fluid kind of lubricates everything. I'll pull the end out, I'll dump it all out, and then I'll put my plunger back in, and I use air. I'm telling you guys probably use at least saline with a bubble. So you'll usually want like 3 cc's of saline in there, and then you'll just add a little bubble to the end of it. And that bubble will compress as we get further in. Anyway, so I get that ready. I'll take this with a bigger drawing needle. Usually this pink one's probably an 18 gauge. And I'll draw up my lidocaine, and I'll just pull the whole syringe full. I'll take it off and switch to your small needle, which is like a 25 gauge, which I don't even, oh, that's probably this one, it's probably a 30 in here. Yeah, so there's your little local needle, and that one's a short one. They usually come with an inch and a half needle, some kids. So, which will bring up something I'll want to mention here in a minute with local needle. And then I'll grab everything I need, my local, my glass syringe that I've got ready, my epidural needle, my catheter, and potentially my connector, and I'll set it on that sterile drape that's on, and I'll just kind of lay everything out right here. And then I also have a garbage can close by. I usually pull a garbage can right here, and so I'm throwing all my garbage into there. So patient's prepped, marked, drapes on, everything's all sterile. I've got my sterile gloves on. When I put them into the position to mark them, then I let them relax and sit up as I do all this. Now I go back and say, okay, we want to go back into that slouch position, pushing your lower back out here where you can feel me touch. And then they'll kind of get into that arch position. Sometimes you got to work in between contractions. I will, if they start contracting right before I start, I'll wait for a minute until it starts coming down. But I always tell them, as soon as it starts coming down and relieving, let me know, we'll get started, because we want as much time in between as possible, because we'll get to a point to where I won't want to stop for a contraction. And so if I can hurry and get it in between, that's the goal. Because they have a hard time sitting still during a contraction. Some people do great. Anyway, I will double check with my sterile drape. You can still check for your hips, check for your placement, or see your mark. I'll still double check my mark, because even though you've got that mark on, they might be in a little bit different position than they were when you marked them, and it might throw off that mark off that space just a little bit. So I always just double check where I want to go, and then I'll even feel the spinous process, and I'll put my thumb there and hold it. And I'm just gonna go right above the spinous process. I'll take my local needle. I personally do a 2 injection technique. A lot of people will just do 1. I'll come in and do a skin wheel off the side, and then I totally pull it out, and then I go right into the skin wheel, the center of it, and I'll inject local. Now, the one thing I want to say about local, using your local needle, if you've got an 1.5 inch local needle on there that's a 25 or greater, and you've got a very thin patient and you can see all their spinous processes, you have to be careful, because an 1.5 inch needle will go through the dura on some people. And if you think you have to local and bury this needle, you may get into the CSF. It's not a big deal necessarily because of the size of the needle. Very unlikely to cause a headache. But if you're injecting some local anesthetic in there, they might start getting some numbing effect, which potentially could mask some other things that you're looking for. So you could potentially wet tap, we'll call it a wet tap, but because of the size of the needle, it's probably not going to